Thank you very much. I'm going to go ahead and present my talk on the echocardiographic evaluation of pericardial diseases, and we're going to focus on constrictive pericarditis versus restrictive cardiomyopathy in this particular talk. The normal pericardium is about 1 to 2 millimeter thick. It's got the outer fibrous layer and the inner serous layer, and both the visceral and the parietal pericardial layers provide a support during the cardiac motion by anchoring the cardiac structures. It provides lubrication, and to some degree it has been thought that it provides also a protective function to the cardiac epicardial surface. But the most important aspect is it prevents cardiac distension, particularly during diastole. It helps abnormal excessive dilatation of chambers, and this is something seen immediately after pericardiectomy. During the post-surgical phase, you may see increasing size of the chambers, which of course over a period of time adapts itself, but to some extent it also helps in limiting the cardiac distension during the phase of cardiac filling. Now, constrictive pericarditis develops whenever you lose these functions of the pericardium. Particularly, it alters the distension of the cardiac chamber. It has a constricting element. So during the phase of diastole, the intrapericardial volume is reduced. So the diastolic distension of the chambers is compromised. Plus, in addition, the lubrication function is gone. So the normal cardiac motion that occurs inside the pericardium is eliminated. And this altered cardiac deformation also leads to development of difficulties in providing a normal relaxation and filling of the left ventricle. The pathology of the constrictive pericarditis has been studied extensively. The pericardial layers, when they thicken, they can lead to different types of cardiac geometries. And here is an example of all the different types of geometries that may be encountered. Particularly, there's a predilection for the thickened part of the pericardium to happen near the cardiac base, particularly in the AV grooves. And it can happen asymmetrically around the chamber. It can be present more focal and localized over the chamber, like in the right ventricle. And these lead to different types of hemodynamic presentations, which may be challenging to recognize during clinical imaging. But independent of the mechanism, it impedes the function of diastolic filling, causing elevated filling pressure inside the cardiac chambers and systemic venous congestion. The thickening of the pericardium can be appreciated using echocardiography. In fact, using transesophageal echocardiography, as you can see here, this thickened pericardium here over the right ventricle, and here is a CT scan, the same thickening of the pericardium. There has been a very good correlation between the transesophageal measured, echocardiographic measured pericardial thickness and also the CT pericardial thickness. However, despite the consistency of the information with regards to pericardial thickening, it's extremely important to understand that thickening of the pericardium does not mean constriction. It could be present with the hemodynamic features of constriction, then cause constrictive pericarditis. But isolated thickening, if you want to rely upon, may not necessarily be consistent always with constrictive pericarditis, the clinical presence of constrictive pericarditis. In fact, this particular study from Mayo Clinic long back showed that the pericardial thickness can be normal in several patients, in almost about 25% of patients with constrictive pericarditis. It's the altered material properties of the pericardium. It's the altered ability to deform in the diastole and the compliance of the cardiac chamber along with the pericardium. That what leads to the physiology of constrictive pericarditis. So it's important that although thickness of the pericardium can be obtained using transesophageal approaches, echocardiography approaches, the mere thickening of the pericardium is not necessarily enough for diagnosing the clinical syndrome of constrictive pericarditis. The knowledge about the pathophysiology and the hemodynamic changes that happen with constriction have actually allowed us to understand how in constrictive pericarditis, given the pericardium is altering the deformation of the cardiac chambers, it leads to the systemic venous congestion. So here are the prominent X and Y descent that you see in the jugular venous form. So this is the central venous pressure tracings. And there is also equalization of the A and the V waves. And you get this characteristic pattern that also sometimes can be obtained clinically. If you examine the JVP, you see this rapid descents and a very high elevated jugular venous pressures in patients who are presenting with systemic venous congestion. In fact, the venous pressures can be sometimes so high that you might have to make the patient stand up, and then only the upper level of the venous columns may be appreciated. But nevertheless, you get this characteristic features on the central venous pressure. And when you do the measurements in the cardiac pressure measurements, you get, there are certain characteristic features that were in the past described. For example, equalization of the LV and the RV diastolic pressure. Typically, the right ventricular systolic pressure and the PA pressures are not very high in constrictive pericarditis, so less than 50 millimeters mercury. And also the end diastolic pressure of the RV is elevated, so that if you have the ratio, which almost increasing more than 1/3 of the systolic pressure of the RV, the diastolic pressure, then it indicates an elevated filling pressure. So, however, these some of the older criteria of hemodynamic features of constrictive pericarditis, however, were not shown to be very reliable for the clinical diagnosis. So there was a search for other additional criteria. Lev Hadley provided an insight into some unique features of constrictive pericarditis that has really helped us understand the hemodynamic changes that happen in constriction. And two characteristic features that happen in patients with constrictive pericarditis include the dissociation of the intrathoracic and the intracardiac pressure. And number two, there is an exaggeration of the LV and the RV interaction or interdependence. These features were first described using intracardiac pressure tracings. And here are some of the typical findings that you see. So you have here the pulmonary capillary wedge pressure that is recorded, and you have the LV pressure. Now look what is happening during the phase of inspiration. During the phase of the inspiration, the pulmonary capillary wedge pressure, which is the intrathoracic compartment, is falling down. So you have a reduction or falling down of the intrathoracic pressure. So the pulmonary capillary wedge pressure is falling down, but the intracardiac, and this is the LV pressure, LV pressure is not falling down simultaneously. So you see, therefore, there is a gradient. So there is some kind of a walling mechanism. Typically, these pressures go together and they will decrease down during the phase of inspiration. But there is somehow the pericardium walls off so that the intracardiac pressure, the LV diastolic pressure, somehow does not reduce to the same extent. And as a consequence, this gradient in inspiration is you can see here, there's a difference that is maintained. And the secondly, during the expiration, you see this exaggerated uptake of the pressure. The pressure rises up in the pulmonary capillary chamber. However, the intra LV pressure, the change is minuscule or not as much in comparison to the large change in the pressure that's happening in the pulmonary capillary wedge pressure. So this is some form of a walling mechanism in which the intrathoracic compartment and the LV diastolic compartments do not have the same transmission of the pressure. So there's a gradient, exaggerated gradient that is happening during the inspiratory and the expiratory phases that is not transmitted into the intracardiac chambers, the intra-LV pressures. And the second phenomenon that happens is the phenomenon of what is called as interventricular interdependence, and that is seen here in form of the systolic pressure. Now look at the pressure of the right ventricle during the inspiration and the pressure of the LV during the inspiration. So so you can see here during the inspiration, the pressure jumps up in the RV side. So the RV systolic pressure is increasing, and there is a reduction of the pressure on the LV side. And during the expiration, you can see the RV pressure is falling down and the LV pressure is increasing up. So you can see here that the LV and the RV pressures are reciprocally changing during the respiratory cycle. In inspiration, the RV goes up and the LV comes down. And during the expiration, the RV goes down and the LV comes up. So this is a phenomenon which was recognized as exaggerated interventricular interdependence and allowed us to understand the unique physiology and hemodynamic changes that were happening in patients with constrictive pericarditis. Now, the quest to understand using echocardiography, actually for constrictive pericarditis, you can see here an evolution over a period of time from M mode to spectral tracking. The same way our understanding of constrictive pericarditis using echocardiography has continuously evolved. Each time a new technology that has come in, it has offered a new observation that has allowed us to recognize some typical features of constrictive pericarditis in the clinical practice using that specific attribute of echocardiographic application. For the first time, when pericardial disease was described, Dr. Feigenbaum described the pericardial effusion, and after that, the same applications have continued for understanding the pathophysiology of constrictive pericarditis. And one of the most important changes that were first described using M mode and 2D echo was the abnormality of the septal motion. Now, the abnormality of the septal motion that is seen in constrictive pericarditis are of two types. One is called as the septal shudder. So there is a movement, you can see here, a sharp movement, a bouncing motion of the septum during each and every cardiac cycle. So you can see here how this large motion, high frequency motion that is happening during diastole. This is called as the septal shudder. Plus, in addition, what you see is that the septum is moving from the RV side to the LV side and vice versa. So there are two components of the septal abnormal septal motion, and that is a septal shudder and the movement back and forth from the RV towards the LV. So this will be an inspiration. So this is the respiratometer, and you can see here during the inspiration, the RV volume is increasing. So the RV size is increasing here, and the septum is moving towards the LV, and the LV size is reducing. Whereas during expiration, the LV size is increasing and the RV size falls down. So this will be the expiration. And the septum is moving towards the right ventricle, and this is the left ventricle. So you can see here the moving back and forth of the septum. But in addition to that, then this abnormal high frequency motion that is happening in the septum. So there are two components. Now these two components can also be recognized on 2D echocardiogram. This is the septum. You can see during the respiratory cycles it's moving back and forth. You can see here it is moving back and forth. Plus, in addition, there is a very high frequency movement, intermittent movement or shudder-like movement that is happening during each and every cardiac cycle, which is of course much better recognized during M mode echo. So in the current era, we continue to use M mode echo for understanding this abnormal septal motion in constrictive pericarditis, and it provides much better temporal resolution of this abnormal septal motion and can be very useful for the diagnosis of constrictive pericarditis. And what this means that there is the septal shudder that happens, the quick movement that is happening is because of a large quick equalization of elevated filling pressure that is coming in from the RA and the LA towards the RV and the LV, that puts like a large frequency motion, sudden movement to the septum. Plus, in addition, the interventricular interdependence, the exaggerated interventricular interdependence that happens in the constrained environment of a fixed pericardial volume causes this back and forth shift of the septum. And this is a very, very important and classic sign to recognize in clinical practice for understanding constrictive pericarditis. Of course, one has to differentiate the abnormalities of septal motion that can happen in other types of diseases, like you can have a left bundle branch block, or you can have immediately post pericardiectomy, you can have chronic obstructive pulmonary diseases. There are other conditions, atrial septal defect, where you can have abnormal septal motion. You need to recognize the differences, and merely calling out an abnormal septal motion is not important. There are very specific features that need to be recognized for calling a constrictive pericarditis. However, if one looked into just the mode features of IVC bounce, and there was another feature, which was the LV posterior wall flattening that was described, the sensitivity and the specificity of diagnosing constriction is not that great. You would not see them in all the patients, or you may have difficulty in differentiating from other types of abnormal septal motion. So the quest for finding other variables for understanding constrictive pericarditis continued subsequently. With the advent of the Doppler, one was able to revisit the hemodynamic features of constriction, and there were a plethora of articles that came in about how different velocity features using Doppler could be used for diagnosing constrictive pericarditis. So typically, if you would place a pulse wave Doppler over the mitral valve tips or over the tricuspid valve tips, it will allow you to record the signals. And what you see here is the features of the varying flows during the cardiac cycle, as we came to know about how the walling of the pericardium creates variance in the flow that happens across the transmitral valve during inspiration and expiration, plus how the shifting chambers, shifting interventricular septum and causes differences in the volume of the chambers. Both of these features are associated with changes in the transmitral velocity. The transmitral velocity are exaggerated and bigger during expiration and reduced during inspiration. Vice versa, the transtricuspid velocity are exaggerated during inspiration, and the velocities reduce during expiration. And in addition, we see certain changes that are recognized in the hepatic vein and also in the superior vena cava that can be recorded using pulse wave Doppler. And it's very important to recognize some of these features as well, particularly during the phase of inspiration, when the flow is coming inwards into the right ventricle. You will see a forward flowing velocity in the hepatic vein. And during the expiration, as the flow reduces on the right side, you start seeing an attenuation of the velocities in the hepatic vein. In place of those forward moving waves, you see actually reversal flow of the flow, and this reversal of the flow is very well characterized in the hepatic vein and can be very useful to diagnose constrictive pericarditis, and we will see some of those examples in the next few slides. So here is an example of a transmitral filling pattern. You can see here, this is the inspiration and this is the expiration. If you look into the first beat, during the inspiration and the first beat during the expiration. If you look into the peak of the E wave and the peak of the E wave from inspiration to expiration, you see a large change of velocity from 0.6 to 0.9%. And this change is 34%. So you can see here a large change that happens from the first beat after inspiration to the first beat after expiration. And this change, if it's more than 25%, can be useful for diagnosing the findings which are useful to confirm the presence of constrictive pericarditis. So more than 25% variation in the respiratory flow in the mitral E velocities, that is in patients with constrictive pericarditis. Conversely, on the right-hand side, you can see here the transtracuspid flow velocity. So this is the inspiration and this is the expiration. This is the E wave after the beginning of the first inspiratory cycle. So the E wave and the first E wave after the beginning of the expiratory cycle. So you take from here to the here, you see a large change from 0.6 to 0.3. So there is a 50% or more change in the transtracuspid inflow peak E velocity. And these flow velocities, typically, if they are more than 40% in the tricuspid E velocity, that can allow us to diagnose the presence of findings that are consistent with constrictive pericarditis. Same way, if you look into the hepatic venous signal, here is a respirometer. So this is the inspiration and this is the expiration. Now in the inspiration, you see this is the ECG waveform, this is the QRS. So this is the S wave and this is the D wave, the diastolic wave. So both the waves here are forward looking, or they're moving in the hepatic veins towards the IVC. This has been taken from the hepatic veins, so the flow is moving towards the IVC. So this is a forward movement in systole. This is a forward movement in diastole. Now let's come to expiration. So this is the expiratory cycle here. So let's look into the first beat up in the expiratory cycle. In the expiratory cycle, you see this is the S wave, the systolic wave, and there should be some wave here in diastolic wave. Well, in place of that, you see a reversal and one more reversal. So this is the systolic flow in the antegrade direction towards the IVC, followed by a systolic flow reversal. It rapidly moves up and gets moving in the opposite direction. This is an exaggerated flow reversal in systole, in the early part of systole, and also in diastole. Instead of moving forward, you're seeing a backward wave. So this is a diastolic backward wave, a reversal, a flow reversal wave. When you see this large, remarkable flow reversals that happen with expiration in comparison to the flow velocity in inspiration, this is diagnostic or specific for the presence of constrictive physiology. So this is again a very important finding for patients with constrictive pericarditis. So inspiration, expiration, and then you can see the changes in the flow velocity, particularly the appearance of flow reversals in diastole that allow you to diagnose the physiology of constrictive pericarditis. Now this reversal is happening because during the expiratory phase, as you would remember, the right ventricle is not taking in any further flow. And in fact, the flow is reversing in the IVC, and the IVC is usually engorged and very plethoric. And they could be bright Rolu formations that are also seen. So a plethoric IVC with exaggerated flow reversals in the hepatic veins during expiration allows us to be consistent with the physiology of constrictive pericarditis. And these changes all in respiratory cycles can also be appreciated in the SVC flow. You can see here the changes that have been recorded from the SVC in inspiration and expiration. However, I would have to admit that the routine Doppler information from the SVC may be a little challenging, and one relies a little bit more in the hepatic vein flow signal velocities. Typically in clinical practice, transmitral, transtracuspid, and the hepatic vein flow velocities would allow you to provide some consistency in diagnosing constrictive pericarditis. The SVC flow can be useful, particularly in patient when the large velocity variations can be observed, particularly in patients with with chronic obstructive lung disease. And once we are trying to decide whether this flow velocity changes are because of COPD or constrictive pericarditis, but SVC flow typically is not routinely obtained, or it is difficult to obtain in all patients with cleanly, and may be technically challenging. You may also get features of pulsus paradoxus. So if you have an LV outflow Doppler signals, in addition to the transmitral flow velocity and the transtracheal flow velocity, you may also get the reduction of the flow in the LV outflow with inspiration and exaggerated flow during expiration. So the feature that will be consistent with diagnosis of pulsus paradoxus can be seen in several patients with chronic constrictive pericarditis. When we look into the diagnostic yield of just looking into the transmitral and the transtracuspid and the hepatic vein Doppler signal, again, if you look at them in isolation, you find that the sensitivities and specificities are not perfect, and therefore there was continued quest for understanding more elements in echocardiography that can allow you to understand constrictive physiology. So you now start looking beyond Doppler, and particularly people were confronting a very interesting situation where they were seeing patients with constriction, but there was no respiratory or respirophasic variation that was encountered. So for example, this is a patient whom you can see on fluoroscopy, the pericardium is completely calcified. Completely calcified. This patient is also in atrial fibrillation. Now you can understand in a patient who's got an atrial fibrillation, there can be a lot of variation related to RR intervals itself. To top it, if you look into the hemodynamics, you can see here the RA pressures are very high. There is that Y descent that you can see. There's a square root sign that the RV, LV pressures are equilibrated. And in this situation, you can see the RR intervals are changing, but there is very little difference in the pressure changes, or the characteristic pressure changes during the respirophasic intervals are a little bit difficult to see here in this particular patient. If you see the transmitral E velocity, despite the changes in the RR interval and the patient having respirophasic cycles, the E wave is almost near the same. This is a patient who has got a very high filling pressure. The LA pressure and the RA pressure are so high, are very high, that it is leading to inability to diagnose constrictive pericarditis. So even if you try to do respirophasic maneuvers, you'll not have you'll not be able to bring forth the typical changes in the respirophasic velocities because of very high filling pressures. So for these reasons, there was a need to look into some other parameters beyond just transmitral and transtracuspid flow velocities. Mario Garcia and colleagues proposed looking into tissue Doppler velocities, particularly looking at the mitral annular velocities, which allows the longitudinal descent of the mitral annular plane to be measured, and the speed of the annular descent to be measured during diastolic phases. They showed an interesting behavior. They showed that in patients with constrictive pericarditis, the mitral annular descent during early diastole, the speed of the descent was preserved, in fact, a little slightly exaggerated than the normal individuals, whereas it will be highly attenuated in a patient who would have basically restrictive cardiomyopathy or myopathic process inside the ventricle. So this change or difference in the E prime velocity became a very important feature that has been now looked upon and as a consistent feature for diagnosing constrictive pericarditis. And there were some additional features that happen that are unique in patients with constrictive pericarditis. You see a phenomenon called as annular paradoxus. Uh, if you look into E by E prime, and elevated E by E prime usually goes hand in hand with an elevated filling pressure. So there will be, if a patient's filling pressures are high, the pulmonary capillary wedge pressures are high, usually E by E prime is elevated. However, in patients with constrictive pericarditis, what we find here is a dynamic mitral annulus makes a big attempt to move the annulus longitudinally back and forth. And despite the presence of a restrictive filling pattern, you can see a very tall E wave here, and the A wave is very small. So E by A ratio is more than 2, despite a restrictive filling pattern, which indicates elevated left atrial pressure, pulmonary capillary wedge pressure. Because of the exaggerated annular motion, the E by E prime ratio remains normal or low normal. So this is called as an annulus paradoxus in comparison to other situation in which heart failure because of myocardial diseases or restrictive cardiomyopathy would cause the E by E prime ratio to go up. And another feature that can be seen in patients with constrictive pericarditis is called as annulus reversus. Usually the lateral wall velocities are higher than the septal wall velocities, but in constriction, because the free wall gets adhered to the pericardium, it moves less. So the lateral velocities go down versus the septal velocities, they go up. So there is a reversal of the velocity peaks of the early diastolic filling, that's the E prime velocity, is attenuated in the lateral wall and exaggerated in the septal wall, which is converse or reverse of what happens in normal individual. The lateral annular velocities are higher than the septal annular velocities in early diastole. So this feature was also seen by and described and is known as annulus reversus. However, if you just look into early diastolic velocities alone, there can be some challenges. For example, if you have a heavy calcification around the mitral valve annulus, or if you have a patient with a metallic prosthetic valve or prosthetic material in the annular plane, you may not be able to get a very well defined mitral annular velocities, and therefore for those reasons there was a change towards looking at multiple parameters. So looking into multiple, starting from MO to the Doppler annular velocities, to look at multiple parameters and finding some consistency of information for diagnosing constrictive pericarditis. There has also been an attempt to look beyond mitral annular velocities to try to understand how newer techniques can be used. And here is a description of annular velocities, how it functions. Now you can see here that the annular velocities are really, really very reliable in a great way. If you see a very well preserved E prime velocity in a patient who has come with right heart failure, or is you're suspecting constrictive pericarditis, then you know that this patient likely has some constrictive physiology going around. So if you see a normal or high normal E prime velocity in a patient with heart failure, pause and think about constriction. Speckle tracking echocardiography is another technique that has been recently applied, although some of the applications have not been and observations have not been recorded into the guideline statement, but can be principally used to understand the same physiologies. So here is an example of a patient who's on the table. And in fact, this is a patient who was brought in for a pericardial tap. And I was called in, and this patient is lying on the cath table, and this is the image that you see. Well, the first thing that you see here is that this is not a pericardial effusion. This is a patient who's got a very large pleural effusion. In fact, the pericardial layers are very densely adhered. What you see here is the abnormal septal shudder. You can see here the abnormal septal motion. And then in addition, you look into the physiology of using Doppler techniques, you will see here that there is an element of respiratory flow. No, the patient is extremely tachycardic, and therefore it is difficult sometimes to get the nice signals, and particularly it is challenging on a patient who's lying supine on a table. But you can get some impression that there is probably transmitral flow velocities are changing during the respirophasic phases. The IVC is extremely dilated. But the most important and impressive is look at the mitral annular velocity. The mitral annular velocity is extremely high. It is 16.5 centimeters per second. In a patient who has got an elevated filling pressure, who is in heart failure, this exaggerated mitral annular velocity, look at the right ventricular systolic pressure is measured as 45 millimeters mercury. This is extremely concerning for diagnosing a constrictive physiology. This is a patient who's on the table who's got constrictive pericarditis. In fact, we aborted the whole procedure and diagnosis just changed because all of these features, one after the other, starting from the septal bounce, transmitral flow velocities, dilated IVCs, and you see here also a mitral annular velocities, which is extremely high. In a patient with heart failure, normal LV function, this is all features consistent with constrictive pericarditis. So we went ahead and did an additional step to look into how this LV is moving. Now you can see here, this is a speckle tracking echocardiography from the lateral side to the septal side, and you know, this is all information. Interestingly, this LV is attempting to squeeze in a longitudinal direction. So longitudinally, it is trying to contract and expel and create a stroke volume in a constrained environment. So the longitudinal deformation is still relatively preserved. This is minus 17. So you can see here, it's very close to minus 20. So the longitudinal strain of this ventricle, despite challenged environment of a heart failure, is very near normal. This again is a feature that suggests that the myocardium is able to contract longitudinally and is able to try to maintain a stroke volume, and again goes consistent with the features that this is not a myocardial disease. This is a normal myocardium which is moving normally in the longitudinal direction, and it helps us to eliminate myocardial disease as a cause of heart failure. Versus another patient looks very similar. And this is, of course, the patient's CT scan showing the pericardial thickening. You can see the full red carpet, which indicates a normal strain. The global strain is preserved. This is the CT scan. You can see the large pleural effusions and also there is thickening of the pericardium that is allowing you to understand that this is a constrictive pericardial disease, pericardial constriction as underlying physiology, and you have clutched the diagnosis. This is another patient who looks similar, very similar looking patient. You got an effusion on the top, and this is again being brought in for a tapping. Again, the LV function is relatively preserved, but it looks the LV is slightly thickened. But what you see here again is the mistake that this is not a pericardial effusion. This is a pleural effusion, and what you see here is the pericardial layers, the visceral and the parietal layers are sliding nicely over each other, so they are not adhered with one another. The sliding well, the underlying myocardium is sliding well. So this patient has something else going around. Now let's look into the Doppler pattern. Again, you see a restrictive filling pattern, But most importantly, that you see here, the mitral annular velocity is markedly attenuated. The E prime, the mitral is 4 centimeters per second. This is, compare that other patient that was 16 centimeters per second. This LV is having difficulty in relaxing in the longitudinal direction, and the velocity is only 4 centimeters per second. And of course, the patient has got elevated pulmonary arterial pressure. You can see here RVSP, which is the TR signal is over 3 centimeters per second. So this patient has preserved ejection fraction. E by E prime is elevated. So you have 8 over 4, nearly 20 E by E prime, and has got a markedly attenuated E prime velocity. And if you do a strain in this particular patient, you're looking into the deformation in fourth chamber. And what you see here is a very markedly attenuated performance. You can see here, if you look at the overall picture, there is a cherry on the top, and the numbers are really, really pale. So this is a markedly attenuated longitudinal function. So this is a patient who has got, if you would apply the strain features that will indicate some form of infiltrated myocardium, like, for example, cardiac amyloidosis. And this patient has elevated right atrial pressures, left atrial pressures, pleural effusion. The patient is in heart failure. This is very, very consistent with the restrictive cardiomyopathy, for example, with an infiltrate disease like constrictive pericarditis. So you have used strain here in this particular example for uncovering presence of a myocardial disease. The myocardial disease, the dysfunction is very well identified, and incrementally adding the information allows you to diagnose a patient with restrictive cardiomyopathy in comparison to the other patient with constrictive pericarditis. So there is disparity in the pattern of how not only the ventricles contract, but also the physiology of the cardiac function, which can be uncovered using Doppler mechanics. So serially adding up 2D MO Doppler strain patterns can allow you to differentiate from a myocardial disease versus a pericardial disease, and differentiating constrictive pericarditis from restrictive cardiomyopathy. There is also a role for imaging beyond echocardiography, which is important to understand. There is complementary information that can come from CT and MRI techniques, particularly constrictive pericarditis. The physiology, once diagnosed, it needs to be associated with the clinical story. If the clinical story suggests that there is an ongoing inflammatory process, even if a patient has a constrictive physiology and as it is in heart failure, you should look out for reversible features like a reversible inflammatory state. And that can be recognized using inflammatory biomarkers and looking into reversibility of the inflammatory phenomenon using delayed gadolinium enhancement. In fact, if you see the delayed gadolinium enhancement disappears after anti-inflammatory therapy and the features of constriction disappear, you have in fact diagnosed a reversible process, and therefore these patients would not be required to be subjected for surgery. It's very important to understand the features of constrictive physiology are reversible in a patient who presents with an inflammatory state and who can respond to anti-inflammatory therapies, and therefore constrictive physiology, once diagnosed, needs to be seen with a lens of whether there is an inflammatory state, and that could be diagnosed using delayed gadolinium enhancement. Also, MRI techniques have developed that allow you to get consistent information that is obtained from echo. For example, the abnormal septal motion and the exaggerated interventricular interdependence can be diagnosed using also MRI techniques that you can see here in this particular patient who's got constrictive pericarditis, that there is marked abnormal septal shift that is seen. In addition, what you also see, this is a CT scan of the same patient. The patient has a very thickened pericardial layer over the right ventricle. And there is evidence of some inflammatory state. This is a delayed gadolinium enhancement. All of this information is very important. This patient was found to have an inflammatory state, and therefore an initial attempt was made for seeing that if the patient would respond to anti-inflammatory medications. This patient, of course, after a period of time, continued to stay in features of constrictive physiology with elevated filling pressure. Finally, of course, was brought back after several months, and pericardiectomy was done. You can see here the features of elevated filling pressure. Ascites, engorged IVC is seen here. This patient ultimately was subjected for surgery, and you can see the thick rind of pericardium that was exposed and removed from over the right ventricle. So this is multimodality imaging in very challenging situation that allows us to do incrementally the decision towards the final therapy. But in many patients, the inflammatory state may subside and the features of constriction may be reversible. There has been also an attempt towards looking into the mechanics of the ventricles using feature tracking, which can be done. Particularly feature tracking and delayed gadolinium enhancements are very useful for differentiating restrictive cardiomyopathy from constrictive pericarditis. You can see here is a normal individual. You can see here the mitral annular motion is normal, just looks like the normal, and the longitudinal function is normal. And this is a patient with restrictive cardiomyopathy. The annular function is attenuated, and the strain in the longitudinal direction is attenuated. So this is the patient of restrictive cardiomyopathy versus constrictive pericarditis. The myocardial involvement can happen in patients with constriction and is important to diagnose, because if there is increasing infiltration with myocardial disease processes, even in patients with constriction, they may be differential outcome after pericardiectomy. And you can see here that patients who have evidence of myocardial dysfunction, even in presence of constrictive pericarditis, this can be extremely challenging, particularly presence of secondary causes of constriction, like cardiac surgery or previous CABG, may create mixed picture or mixed diseases. So radiation is another example. And these situation, you have to use multiple tools, multimodality strain to understand what is the extent of myocardial disease in a patient who looks like having constrictive pericarditis. And one has to be careful in understanding the reversibility of the disease after pericardiectomy. And some of these patients may not have good survival, particularly with the mixed disease if pericardiectomy is done. So that could be a challenge, and therefore multiple modalities can be extremely helpful. This is the algorithm that has been given by the guidelines. The 2016 ASE diastolic dysfunction guideline document provides this algorithm to look into multiple features. They provide an initial assessment to look into the transmitral flow velocities, particularly in presence of dilated inferior vena cava. So if you have a restrictive filling pattern with dilated inferior vena cava, yes, that goes towards constriction. Then look if there is an abnormal subtle motion that is present, particularly with respiraphasic motion that are present, yes, that would be again towards constriction. Then you look into the mitral velocities if they are completely normal. So this ventricle is behaving like a normal ventricle in the longitudinal direction. You have clinched the diagnosis of constriction. If you have a reduced velocity, then that will be going towards restrictive cardiomyopathy. If you're in between, it could be a mixed disease. You may need more information using strain, using multimodalities. You also may try to look towards other features. For example, if you have hepatic vein expiratory flow reversals, then that's really helpful to diagnose constriction. If you have annulus reversus, then it's again helpful for diagnosing constriction. The diagnosis of constriction and restriction continues to be extremely uh, uh, challenging and requires multiple variables that need to be added together towards the diagnosis. However, if you look into some of these features, presence of restrictive filling pattern, so elevated filling pressure. So this is not necessarily a restrictive filling pattern. This diagnosing presence of elevated either pseudo-normal or restrictive filling pattern, dilated vena cava, abnormal septal motion, and then you've got abnormal mitral E velocities. Then it's restrictive cardiomyopathy. If it is a normal, that goes towards constriction. And that helps us further to be substantiated with the presence of hepatic vein expiratory flow reversal. That really helps us clinch the diagnosis of constrictive pericarditis. There are new technologies using machine learning algorithms, and some of this decision pathways can be integrated. And perhaps in the future, some of these techniques can be used using machine learning approaches to develop a decision pathway that could be more ready and usually and utilized in clinical practice for integration of the information that is often challenging to integrate. To summarize, therefore, for constrictive pericarditis, look for septal shudder, look for the transmitral flow velocities, tricuspid flow velocities, hepatic vein reversals, presence of normal or an abnormal E prime, presence of increased filling pressures as diagnosed by E prime, or a normal E prime, which goes in favor of constrictive pericarditis, and then use of additional modalities like longitudinal strain and other modalities like CT and CMR, which can provide incremental information. Remember that thickened pericardium is not necessarily constriction. You need to have hemodynamic features of constriction, and also pericardial thickness can be normal in up to 25% of patients with constrictive pericarditis. And that constrictive physiology needs to be seen in the lens of an inflammatory state, because constrictive physiology is reversible. And in such situation, using MRI for looking into pericardial inflammation can be extremely helpful. Thank you very much.